you. Good job. Thank you for filling in for Esther. It was such an important talk that we had to focus talk just on FMD alone, but Melissa was going to tell us the other predisposing arteriopathies for SCAD. So I would like to introduce Melissa. She is the co-director of the Women's Heart Health Program at Mass General Hospital, director of the Corrigan Fellowship in Cardiovascular Disease in Women, and director of the MGH Multidisciplinary SCAD Program. As many of you know, Melissa is a strong advocate for SCAD patients as well, and has done a lot of research on SCAD. She is a member of the Scientific Advisory Board of the SCAD Alliance and member of the iSCAD steering committee. We'll be hearing from her for a few talks in this conference. So welcome back again, Melissa. Did we get you set up?
I think we're good. Thank you very much, Dr. Saw and your colleagues for inviting me. I have woken up tonight and my jet lag is better for a nice workout this morning. So in the next 15 minutes, I'm going to talk a little bit about these things that are pretty uncommon. I mean, I think we've heard about things that are more common when patients present with SCAD, and I'm going to talk about sort of the less common things. And at first when I got this topic, I was like, wow, how am I going to fill 15 minutes with something that only affects 3 to 5% of SCAD patients? But then as I started delving into some of the data, I found it extremely interesting, and I think this is a somewhat complicated topic. I have no disclosures pertinent to this talk. And I think most of us in the audience really have to sit back as we hear about SCAD in the next day and a half. We're going to really absorb a lot of presentations about SCAD sort of from the 360-degree view, and it's going to really make us think about what is the underlying etiology. Do a lot of things happen at the same time in a patient who's vulnerable? But really, I think in the back of our minds, we're really struggling with this idea of is this an underlying vascular disorder that we have just poorly understood thus far? And I think if we look at some of the features of clinically of the patients who have SCAD, it really reinforces that possibility. So we certainly know about the FMD piece. We heard very eloquently about that just now. So if you want to point, I guess I use my finger. Okay, so FMD. Celiac artery dissections, often seen when we do thorough vascular screening with CTA protocols. Intravascular imaging, as we see here, also can demonstrate evidence of vascular abnormalities. But however, we also know these patients clinically present with histories of things like migraine headaches, preeclampsia, hypertension, and things like infertility, which we think may have some role with the microvascular bed. So really, I think if we look at the SCAD patient, whether they be male or female, we see that there are these little clues that suggest there may be an underlying vascular abnormality that manifests in different vascular beds. I want to start with a case of one of my most favorite, lovely patients. She's 20 now, she's 28, but she presented at age 26. She's a software engineer for one of the most successful international software companies. She's had quite a number of health struggles throughout her life. Very severe scoliosis as a young woman, presented with a renal artery dissection at age 18. However, persevered, went on to get a PhD at a very young age, and studied very hard. Living in Seattle, she developed severe chest pain one morning after hearing some devastating news. She also had a bad headache, really right before the onset of the chest pain, and she took Zomig, which was her usual treatment for her migraine headaches, which were quite severe. She knew enough to call 911. The chest pain was pretty bad, and she knew that there was probably a concern given her underlying conditions. Presented to the closest emergency room. Physical exam is quite remarkable with this lovely young woman. She has very translucent skin, she has blue sclerae, she has severe kyphoscoliosis despite Harrington rod placement. She actually gained 5 inches when she had Harrington rod placement, and she has somewhat dysmorphic but beautiful face. Her ST EKG revealed ST depression, no ST elevation, and her tone was elevated. Her pain went away with some nitroglycerin in the emergency room. She was treated as an ACS, was started on IV heparin, and taken to the cath lab. These are her initial images, and you can see sort of mildly to moderately tortuous vessels, not as severe as some of the examples we've seen, and there is clearly in sort of at the takeoff of the first big diag, there's disease involving the LAD, sort of procs into the mid vessel, but there's TIMI-free flow, and you can see that that diagonal vessel is also involved. And then perhaps at this OM1, there's a sort of a focal area of involvement in the distal vessels as well. She was actually quite stable, felt pretty good. However, given this appearance, and I do have one more, I think, image to show you from this. I didn't spend a lot of time on images, it's really, that's not the bulk of this talk. But because of her presentation and people weren't really clear what was going on, she was loaded with a GP2-3A inhibitor. And heparin was continued, she was given DAT and sent to the floor. She then, as you can see her rods here, she then, this is just another image of that same first image of cath. She then developed worsening chest pain after the GP2-3A inhibitor was started. She, at the baseline, or a wall motion abnormality was very marked in the anterior territory on a bedside echo, troponin 1 after 3. And so she was taken back to the cath lab, where this is what they found. As they took more shots, you know what happens, things got a little bit worse, and she actually had, at the end of the case, 0 to 1 flow in the LAD as well as in the OM. Her RCA was spared. She was managed conservatively because she did improve clinically. They stopped anticoagulation at that time. The cath was complicated by a right iliac artery dissection. While in the hospital, she did undergo screening that revealed left vertebral abnormality, but no aneurysms in her brain. And other than the iliac artery complication of her cath, there was no evidence of the old renal artery dissection that she had had as a younger woman. And she was discharged and returned to Boston, where her family lives. So we have managed her. She's been very carefully managed for her dilated cardiomyopathy. She's never had any chest pain. She was able to complete a stress test, a limited stress test given her physical abnormalities, and has done very well, completed cardiac rehab now a year and a half ago, and is doing quite well. Now, of course, the plot thickens. And if you ask me what's the additional history, well, she was in Seattle while living there, visited Dr. Peter Byers, who's the world expert on type, the kyphoscoliotic type of EDS, which in fact she had been diagnosed with a positive frame duplication in exons 10 through 16 in plot 1. And in fact, that indeed is what she has. And this is a perfect example of why taking care of SCAD patients really does take a village. You know, I'm that little gray person, gray thing in the center, but to manage this complex patient, I've had to include help from my vascular radiologist, one of whom is here. We had to include our vascular medicine specialist to help me follow and determine how often we need to screen her in an asymptomatic patient with these complicated vascular issues. We've had to include a vascular neurologist because I didn't know how to manage her migraine headaches, which she still has. Certainly in the setting of having Zomig, treating a migraine, and then having chest pain, we were quite concerned about using triptans and did not want to use those in the future. So he's helped us manage that. She did very well with the team in cardiac rehab and has had a lot of help with behavioral management for anxiety, and certainly had already seen a world expert in medical genetics, and that was one area where we really didn't have to do much. Interestingly, kyphoscoliotic EDS is relatively uncommon. It's pretty rare. It's a recessive mutation with some major and minor criteria, but was thought not to be, vascular complications were thought to be actually quite uncommon. I will say, however, she did present with a renal artery dissection at a young age, so certainly she had already manifested that she was one of those people that was more likely to have vascular complications, which indeed she had. So, you know, I think, and Dr. Hayes showed similar sort of her overlapping diagrams earlier, as we think about when patients present with SCAD, where are we in this continuum of symptoms, of presenting triggers, and then underlying vascular vulnerability. And sometimes it's really hard to know which is the major manifestation. So what I'm going to talk about is under the vascular vulnerability section, the things that aren't pregnancy related, because that does in fact cause vascular vulnerability, as I'm sure we'll hear from Dr. Trummel. But I'm going to talk about vascular things that aren't FMD, and that might be either collagen vascular disorder or inflammatory conditions. And so as you can see, that would include under the collagen vascular or genetically mediated vasculopathies, and then the rheumatologic conditions. So if we look in general as how common are these other sorts of things and predisposing factors for SCAD, and we look at Dr. Saw's beautiful work that was published earlier this year, we'll see that in fact it's quite uncommon that we'll have a systemic inflammatory condition or a connective tissue disorder as sort of a primary feature of our patients who present with SCAD. However, if we look at how commonly we see vascular abnormalities or vasculopathy, we see that it's pretty common. And in this sort of review that was just published this year of all of the different studies that have done vascular screening, we can see that it really goes from about 12.5% of cases up to about 65 or 63% of cases. And I think the more common that CT is used, the higher the number of cases where vascular abnormalities are identified. But I think it's really clear that we all recognize that everything that is vasculopathy is not FMD. And in preparing for this case, I actually contacted not only the speaker that was supposed to give the talk for me, Dr. Kim, but also the vascular medicine person that I refer to in my own institution to help understand how they in their vascular practices differentiate FMD from other etiologies of vasculopathy. And in fact, Dr. Kim was able to just answer this with her quote in this paper that she wrote, where she said, "Given the lack of a non-invasive diagnostic gold standard for FMD, it's difficult to ascertain whether the findings of arterial dissection, aneurysm, and excessive tortuosity seen in SCAD are distinctive manifestations of FMD." And that's about the same answer that I got from Dr. Weinberg, who told me that FMD is a pathologic diagnosis. I think that we all do, however, recognize that there are clinical features, as we just heard, that help us have a greater certainty for making that diagnosis of FMD. Now, what we don't want to miss is a connective tissue disorder, right? And when we look at SCAD patients, we recognize that they are sort of a mystery, and it's our jobs to sort out what could be there that we need to identify so that we can decrease the risk of long-term poor outcomes. So these are just some of the connective tissue disorders that we think about in general, so things like Marfan syndrome, Ehlers-Danlos, neurofibromatosis, not so much with SCAD, Louis-Dietz. However, if we look at those that have distinctly been identified with SCAD, they are these conditions. So vascular EDS is probably the most common genetically mediated vasculopathy, and again, extremely rare. In the Mayo Clinic series, 5% of patients had positive genetics for vascular conditions. 2 of them were, at least in their publication of 2016, 2 were EDS, 1 was Marfan. In our series, which I'll show you, is a little bit different. Marfan has clearly been associated with SCAD. Louis-Dietz, Nail-Patella, Alport syndrome, but again, pretty uncommon. So 5% in the Mayo, 8% in our series. And when we think about EDS, it's a relatively complicated syndrome. There used to be 6 types, then there were 7 types, and now there are about 13 types of EDS. But I think for us as clinicians, it's important to identify those that have potential vascular risk. So this is a potentially fatal disease that if found and treated and patients are given appropriate counseling can have much better outcomes, and also identify family members who should be screened in a potentially autosomal dominant condition. So the types that really do have the risk, the most common is EDS type 4, so the vascular, with the highest risk of vascular complications. But as we saw in the case I presented, the KS form can also have vascular complications. The others are more likely to give you the lax skin, the sort of parchment-like skin, hyperflexibility. There's a very dominant facies, which I'll show you. But when these patients show up in our clinics, we should not miss them because they really are telling us what they have if we know what we're looking for. Protruding eyes, a thin, pinched nose and lips, sunken cheeks, and a small chin. This is just a list of all the different types of EDS. So this is a guy in our series whose diagnosis was made after he presented with SCAD. And I will say that a few of our folks, like the case I presented, had known EDS, but there have been cases where we made the diagnosis, and that's why it's so important that we look for it. He doesn't have a really typical face, not as much as these other folks who were pulled from our aortic registry. These are some other physical features. Now, I think when we're talking to our patients, not only do we examine them, we're going to ask them history. FMD, not so commonly going to be found in the family history. It's pretty uncommon, in fact, to have that. And if people do have a family history, it's usually renal arteries. EDS, however, is pretty common. If you ask, did you have family members who died suddenly without a known cause, or did they have dissections, it'll be usually greater than 2 relatives that they'll identify. LDS, Louis Dietz, another potentially very dangerous vascular condition that can be associated with SCAD. It also has a typical features with broadside eyes, hypertelorism, much more common that they have aortic disease, however, as opposed to rupture spontaneously of other organs. So again, you want to look for folks. And finally, Marfan. I think we all now have recognized, because a number of very, very famous people have Marfan, what to look for. The wingspan, the dysmorphic shorter waist, longer legs, and arachnodactyly. Again, can be, but also very rarely associated with SCAD. In our genetic evaluation at MGH, we did 73 patients that saw our geneticist. He decided, either based on patient preference, physical exam, et cetera, to order genetic testing. 6 patients had genetically mediated and actionable diagnoses that were poor. The most common was EDS, nail patella, polycystic kidney, and Louis Dietz. I will say we have now had a couple people since that who actually have evidence of beading in the renal arteries, who also had positive testing for EDS, and that's really important because our geneticists used to not send testing if patients had a diagnosis of FMD, and now I've now convinced him that he still needs to do it if there's a high index of suspicion. In a cohort of 32 people, we presented this data at AHA last year. We looked at whole exome sequencing and found disruptive coding variants in 67 constrained areas and genes that are in the coronary arteries. We just repeated this in 100 subjects, and that data is cooking. This is a simplified algorithm of what I kind of do. So if there's a vascular abnormality, is it clear beading? If yes, it's probably FMD. I still look for and ask about family history. For other conditions, if there's tortuosity and isolated ectasia, maybe FMD. If there are multiple vascular dissections or there's a family history of dissections or sudden death, then I will certainly push for genetic testing. And then with obviously wanting to find whether or not there's any evidence of EDS. So in the last couple of moments, I'll just talk a bit about inflammatory disease. It's really hard to know when we see this. It's very uncommon whether or not it's coincidental. We know that stress and anxiety and depression can also be present in our patients with SCAD, and patients with inflammatory conditions often have stress, anxiety, and depression. Those conditions which have been associated with SCAD include SLE, sarcoid, celiac, cryoglobulinemia. In Dr. Saw's series, again, low prevalence, about 4.7%. Interestingly, in one of the first pathologic series of cases, which Dr. Vermani and colleagues published back in 1982, they demonstrated on samples of the LAD taken from a group of individuals, 6 of whom had sudden death, 2 who presented with chest pain, that there was sort of this periarterial eosinophilic infiltrate, and question whether that was involved. But then later on, in fact, last year, the same group actually determined that they think the eosinophilia is secondary to the dissection and not the underlying etiology. So more to come. There is a case of a person with eosinophilic periarteritis in the coronaries who did have a spontaneous coronary dissection. So in summary, vasculopathy is pretty common in our patients with SCAD. The most common form is certainly going to be FMD, but there are things we do not want to miss. So physical exam, family history are critical. SCAD may be the first manifestation of a disease that is potentially, in addition, potentially life-threatening, and we need to look for this. There are clues on physical exam. Inflammatory conditions are pretty rare, and if they are there, it's hard to know whether or not they were directly related. We need more long-term prospective studies to follow these patients. So with that, I will finish. There's my Twitter handle, follow me, and thank you very much.